Duchenne Muscular Dystrophy, commonly referred to as DMD, stands as one of the most severe and prevalent form of muscular dystrophy. In 2025, the landscape for those affected by DMD has shifted markedly, driven by scientific innovation, regulatory support, and new therapeutic breakthroughs. Affecting approximately 1 in every 5,000 to 6,000 live male births worldwide, DMD is a rare genetic disorder primarily impacting boys, and it is characterized by relentless, progressive muscle weakness, loss of mobility, and complications that extend to the heart and respiratory system. Understanding the latest updates in causes, symptoms, treatments, and prognosis is crucial for families, clinicians, and researchers dedicated to improving outcomes for those living with DMD. At the heart of DMD lies a genetic mutation. The disorder results from changes in the dystrophin gene, situated on the X chromosome at position XP21.2. This gene is the largest known in humans, spanning an impressive 2.4 million base pairs and containing 79 exons. Dystrophin, the protein encoded by this gene, plays a critical role in maintaining the structural integrity of muscle cells. When mutations occur, be they deletions, which account for roughly 70% of cases, point mutations at around 20%, or duplications at approximately 10%, the body is unable to produce functional dystrophin. The result is a cascade of muscle fiber damage and degeneration that manifests early in life. Because this gene is located on the X chromosome, DMD predominantly affects males, while females may be carriers and occasionally experience mild symptoms, but rarely suffer severe effects. Symptoms of DMD typically emerge before a child's 6th birthday. The earliest signs often include delayed walking milestones, frequent falls, and difficulty climbing stairs. A distinctive waddling gait and toe walking are common, as are enlarged calf muscles, a phenomenon known as pseudohypertrophy. One classic indicator is the Gowers sign, where children use their hands to push off their thighs when rising from the floor, reflecting proximal muscle weakness. As the disease advances, muscle weakness spreads from the legs to the arms, neck, and trunk, eventually compromising the heart and lungs. By adolescence, many children face cardiomyopathy and respiratory complications, and loss of ambulation by age 12 is typical without intervention. Diagnosing DMD has become increasingly precise in recent years. Physicians employ a combination of clinical evaluation and advanced genetic testing. A simple blood test to measure creatine kinase, CK levels, often reveals elevated values, signaling muscle damage. Genetic testing can pinpoint mutations in the dystrophin gene, confirming the diagnosis. In some cases, muscle biopsy is used to assess dystrophin levels directly. Cardiac and pulmonary assessments are essential to monitor disease progression and manage complications early. The importance of early diagnosis cannot be overstated, as timely intervention can significantly influence outcomes and quality of life. 2025 has ushered in a new era of hope for DMD patients, with several notable breakthroughs in treatment. Perhaps the most promising advance is in gene therapy. In June 2024, the FDA approved delandistrogene moxeparvovec, a one-time gene therapy infusion for children aged 4 and older. This therapy introduces a miniaturized version of the dystrophin gene into muscle cells. While it does not cure DMD, studies highlighted by the American Academy of Neurology in May 2025 reveal that it can slow the decline of motor function. However, researchers caution that its long-term effectiveness and safety are still being investigated, and continued clinical monitoring is essential. Beyond gene therapy, innovative approaches like exon skipping and CRISPR-Cas9 gene editing are being explored in clinical trials. Exon skipping uses synthetic molecules to bypass faulty exons during gene transcription, allowing production of a shorter but still functional dystrophin protein. CRISPR-Cas9, a revolutionary gene editing tool, holds promise for correcting mutations at the DNA level, potentially offering a more permanent solution. While these therapies remain experimental, their potential to transform the outlook for DMD is profound. Corticosteroids such as prednisone and deflazacort continue to play a pivotal role in treatment, helping to slow disease progression, improve muscle strength, and delay loss of ambulation. Physical therapy remains a cornerstone of care, with regular stretching and low-impact exercises helping to maintain mobility and prevent contractures. Assistive devices, including orthopedic braces, wheelchairs, and ventilators, support day-to-day function and independence, allowing children and adults with DMD to participate more fully in life. Managing heart and lung complications is vital. ACE inhibitors and beta blockers are commonly prescribed to address cardiomyopathy, while non-invasive ventilation, NIV, provides respiratory support in advanced stages. These interventions have extended life expectancy and improved quality of life for many. Importantly, prenatal screening and genetic counseling have become more widely available, allowing families with a history of DMD to identify carriers and detect the disorder in fetuses, empowering them with choices and preparation. Ongoing research continues to yield promising results. In March 2025, studies at the Medical College of Wisconsin spotlighted a new therapeutic target, the TRPC6 calcium channel, which becomes hyperactive in DMD and contributes to muscle and heart dysfunction. TRPC6 inhibitors, notably BI 749327, have shown success in extending lifespan and reducing muscle fibrosis and inflammation in animal models. These findings are fueling optimism for future human therapies that address the underlying disease mechanisms. The prognosis for individuals with DMD has improved dramatically over recent decades. Where once most children did not survive beyond their teens, advances in care have made it possible for many to live into their 30s, 40s, and even 50s. Quality of life hinges on early diagnosis, multidisciplinary care, and robust family and community support. Patients are now able to pursue education, engage in meaningful activities, and enjoy fulfilling lives, thanks to comprehensive management strategies. Psychological and educational support are essential components of holistic care. DMD affects not only physical health, but also emotional well-being. Inclusive education tailored to each child's needs, psychological counseling for both patients and caregivers, and community programs that foster social interaction and mental health are crucial. Empowering families, raising awareness, and reducing stigma are key to improving outcomes and fostering resilience. In conclusion, Duchenne muscular dystrophy remains a life-altering genetic disorder, but 2025 marks a turning point in its management. Rapid advancements in gene therapy, ongoing research, and a growing network of support systems offer hope where there was once despair. For those at risk or diagnosed with DMD, consultation with genetic specialists and neuromuscular clinics can provide personalized guidance and support. As science continues to evolve, so too does the promise of brighter futures for every child and family touched by DMD.